Hi, my name is Dr. Ross Hauser. Welcome to the Hauser Neck Center here in Fort Myers, Florida. I'm actually here with Colonel Cope, so thank you for your service to the country here, and I know you're a good example of, what makes America great, so thank you so much. And even your willingness today to talk to us, and often I'll say, on these YouTube videos that chronic diseases may be related to the neck. And one of the things that I wrote was Hauser's law. So I just want to explain what Hauser's law is. And in medicine, there's certain principles that are well known. So I'm hopeful eventually Hauser's law will get well known. But it's basically, if a person has a disease or a symptom, and one of your diseases that you have is Crohn's disease, so we'll talk about that.
Okay.
So if a person has a symptom or a disease and the cause of the disease or the symptom isn't known, if you follow the neurology will lead to ligamentous joint instability. So by Hauser's law, if we looked at Crohn's disease and the colon, the intestines are basically innervated by the vagus nerve, then we just follow the vagus nerve in an individual that has Crohn's disease, then it would lead us to upper cervical or cervical instability. Then if you treat that appropriately, what should happen if Hauser's law applies to this case, then the person should feel better. So if you wouldn't just talk about what led you to Caring Medical and then what happened after we started treating you.
Sure. I actually came because I had a cerebral spinal fluid leak 12 years ago and was still having some residual head pressure and whooshing in my ears. And so at my first appointment, we figured out pretty quickly that my vagus nerve was very compressed. And then I started the curve correction and prolotherapy, and probably really it was the first adjustment in prolotherapy. Almost immediately, my stomach started to growl and just change. I feel it changing. And then by the second prolotherapy treatment, a lot of my Crohn's symptoms, which include frequent restroom breaks, cramping, discomfort, depending on what I eat, because I don't actually take any medication to treat my Crohn's, I just handle it by what I'm eating. A lot of them were gone, and the biggest thing is, this is a little uncomfortable to say, but I'm going to the bathroom way less, and it's a way more normal experience than it has been over the last few years. So that was like the first indicator that I was getting better.
Here, let's just talk a little bit about Crohn's, because I
Okay.
appreciate you doing this interview, because that's the main thing I just wanted to talk about. But we can talk about other things that are better or not better. And the cool thing is you're here for your fourth visit, and on the fourth visit we go over we'll retest you again, so we'll see what things are better and what things aren't.
Right.
So we try to use objective measures to tell whether things are heading in the right way or not. Then when were you first diagnosed with Crohn's disease? And then did they tell you exactly where in the digestive tract it was located?
Yeah, I actually had 2 feet of my lower intestines removed.
Oh.
So it wasn't gradual. It was pretty acute in 2015. I was having severe pain, went into an emergency room and had a stricture, which is, where your intestine bleeds and then heals and it gets smaller and smaller. And that had created an abscess, which is why I was in so much pain. So I was actually hospitalized for 6 weeks. They couldn't figure out initially what was causing the stricture and then, all the inflammation that was in my intestines. And so I had the surgery. They removed about 2 feet. And then from that, they sent the intestines to a lab and they said, you have Crohn's. But I was 35. So it was a very odd diagnosis for me at 35 and not like 7 or 10 when you normally find out you have Crohn's when you're younger. And then I'd never had any issues, and I never had issues leading up to it, just the acute.
No, but you could see where Hauser's law, like let's just say for argument's sake, I'm sure you enjoy your job, but let's be honest, probably being is it a lieutenant colonel?
A colonel. full-bird colonel.
Oh, you are? Okay, so
Yes.
I'm sorry.
That's okay.
Yeah. So how long have you been, why don't you just talk a little bit about that? So how long have you been in the Army?
I have been in for 21 years.
Wow, thank you so much.
Yeah, so.
And then, no, like, I have other friends who are in the Army, and I mean, let's be honest, I mean, there is some stress in your job.
Yes.
So, okay, so let's just say for argument's sake, you're on the computer, because the Army, it is a lot of computer stuff. Even as a colonel, it's a lot of computer stuff. Then there's the stress of the job. Then there's the stress of stuff going on in the world. Plus there's a stress in your normal life. So the combination of it could have caused you to have cervical vagopathy or vagus nerve degeneration. So then the electrical supply to a certain part of your colon gets compromised. Then what happens is when you have the vagus nerve not having good input into the digestive tract, basically the tight junctions then separate, and that's going to cause things that shouldn't get into the colon or the intestines get into it, so then you could have an inflammatory reaction. Then in the human body, it's actually the vagus nerve that resolves things that are bad,
right.
Inflammation that's not so good. So you could see where it could be a setup, at least theoretically, for Crohn's. Then even if you get it removed, if cervical vagopathy, cervical ligamentous joint instability, causing compression and stretch of the vagus nerve is the cause of the Crohn's, and you remove the intestines, well, as you know, Crohn's, it'll just go to the next place, the next place, the next place.
Right.
So you had the surgery, then right away did you feel better? What did feel better? And then when did you start getting symptoms again?
Well, I never had symptoms before, so all my symptoms came after the surgery.
Okay.
And that's when I started having, frequent bowel movements and the cramping and the discomfort. So everything came actually after I had the surgery. And then it's been consistent because I decided that I didn't want to take any medication.
What did they want you to take?
Humira, and I think on Humira the military won't allow you to still serve and be on Humira.
Oh, so that would have been one of the decisions, right? Like you wanted to still serve in the military.
Oh yes, for sure. Yeah.
Okay, and then did a doctor say that the symptoms that you had afterwards, it still was the Crohn's, even though they got rid of it, it's still the Crohn's because you still had active Crohn's?
Yes, they said, this is forever. You'll have this forever, and
Do you know how Humira works?
No, not. I mean, I know
no, but
it's
it's
like
interesting.
an immune inhibitor.
No, but it's interesting. Like Humira is a tumor necrosis factor inhibitor, and then when they do vagus nerve stimulators, so anybody could go on Google, when they do formal studies like with rheumatoid arthritis, and they implant a vagus nerve stimulator, tumor necrosis factor. So by stimulating the vagus nerve either electrically, or if you do curve correction and you get prolotherapy, now you have stability, along with being a calm, caring person and not letting the stress of different things get to you. So that's the response, right? We all have to just, no matter if you're in the military or you're at carrying medical, you gotta you gotta keep your stress at a good level, and control the things you can control and the things you can control. If we do that, then you have high vagal tone. So people who have high vagal tone, healthy vagus nerves, these inflammatory conditions, they're probably not either going to get them, or if they do have them, they're going to remit. I know you're trying to be ladylike, even though you're a colonel, but just to be blunt about it, you were having how many bowel movements a day, would you say, when it was real bad? Like how many? On
a bad, I would say 8 to 10.
Okay, so 8 to 10, and then they were very watery, like almost like it just goes right through you, right? Like really watery.
Yeah.
And I think one of the first things you said to me was, I think you said like a fully formed stool, I think, or something like that. So that's like how you knew, like absolutely something is drastically different, because instead of watery stools, I have.
Yes. I mean, again, this is just funny to me, but like just the toilet paper use is way different when you're going to the bathroom correctly as opposed to not. And so that was another thing. I was like, oh, well.
Like it's actually stool instead of water.
Right. So.
Okay, so how many bowel movements are you having now?
I mean, to me, I feel like pretty regular, just 4 or 5. So if I
Okay.
eat, I have a bowel movement. Which
Okay.
before I got sick, that's how my metabolism was. I have put on some weight, which is fine, but like that was another indicator that for so many years I have not been getting the correct nutrition because I just wasn't keeping any of it in. And so now I've put on some weight to say, okay, well, the nutrients are staying with me. So.
Have you been able to eat any foods that you weren't able to eat before? Or?
So definitely, I mean, before I never really like totally cut things out, but I was just careful. And now, you know, I can eat out with my friends or have ice cream was a big one.
Wow.
And things are pretty okay. So, I mean, I have like a bad day every once in a while, but it's so different.
Obviously, at some point, probably Vegas electrical activity was getting through. It wasn't getting blocked. Then all of a sudden, the tight junction. So in other words, boom, now all of a sudden, like Fort Knox or something, like all of a sudden, like crappy things aren't getting into your mucosal surfaces of your intestines. Relatively quickly, then the digestive tract doesn't get inflamed. And if it doesn't get inflamed, then it starts.
I mean, like I said, as soon as I had my first adjustment in prolotherapy, it was almost immediate that I could just hear a difference in my stomach, and then by the second one, such a big improvement. So,
Awesome.
Yeah, it's been really awesome.
Here, so you know, there was a whole bunch of other symptoms. So why don't you tell us other symptoms that are better, and if nothing's not better, then when we go to look at your neck vitals, and obviously we scanned you again, so we'll go over that together and we'll record it. So what things are better, what things are the same, or if anything's worse, let us know.
Nothing is worse. Everything
Okay.
is better. In fact, my mom and I had dinner last night, and she said, you know, you haven't said very much about your head lately. And it's because everything has been improving. So I had a cerebral spinal fluid leak, and we could never figure out where the leak was. And my theory at this point is that it wasn't a leak. It was just like kinked.
Okay.
And it was
Well, why don't you say what symptoms you were having, or that you thought was related to that? Like,
So when I would do exercise and then sit down and then go from sitting to standing, I would have incredible pressure in my head, whooshing sound in my ears, dizziness, and I never passed out, but I would almost pass out. And so it was manageable for a few years, and then in 2019 it got unmanageable, and I couldn't even like vacuum my house. I mean, I was almost disabled. So to go from very healthy athlete, military, you know, active every day, to I can't vacuum my house. And I saw a lot of doctors, and no one could figure it out. They could agree that something was not right, but they couldn't figure it out. And so I found you, and the first test that I had, we pretty much figured out that my C1 and C2, there was instability there, and that was what was, you know, affecting my vagus nerve and the one vein that was causing pressure in my
one of
head.
your jugular veins.
Yeah.
Did you make any adjustments with like your computer or anything? Or did you change your sleep position?
So I'm working on the sleep position still. That one's hard for me.
Because, you know, we showed you which sleep position was best for you.
Yeah.
Yeah.
Laying on my left side and head up. I think I'm accustomed to like going like this, so I have to work on putting a pillow there. And then I just changed the amount of time I'm on computers and phones.
Good.
And so that has really helped as well.
Okay, so any vision symptoms, swallowing symptoms, tachycardia, boom, 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 your sleep, like has anything else changed or?
So the tachycardia, when I was going from sitting to standing, again, day-to-day activities, all of that has gone. If I push it, I tried to swim a couple weeks ago and then like intentionally walk, and then I still have some symptoms, but nothing like it was before. So.
Okay, good.
Yeah.
And did you, prior to seeing us, you had any blurry vision or swallowing difficulties?
I never had swallowing difficulties. I had lots of vision issues early on when it happened in 2010.
Okay.
One of the things that we discovered here was that my pupils were enlarged.
Right.
And so as soon as you said that to me, I was like, this makes so much sense, because for years I would see doctors and say, something's wrong, but I couldn't pinpoint it either. And
do you have light sensitivity or no?
I had light sensitivity, but it was almost like the aperture was so big I couldn't see. Like it was like a
Okay, you just got used to
fishbowl vision.
Yeah, you got
or
used to
something.
like almost like not having clear vision or
Right.
whatever.
Yeah. And so-
Have you noticed any visual changes, good or bad, since we've been seeing you? Or?
I don't think they've been like the most profound change, but I haven't seen any issues.
Okay.
So.
Okay. Any ear fullness?
So I had ear fullness on both sides, and the left side I think is almost completely resolved. The right side, which is where my C1 likes to hang out, is still occasionally full.
Do you feel like you can hear better?
Yeah. I mean, I just feel, I don't know how to describe this. I tell my friends every time I come, I'm like, it's almost like a euphoric experience to have been sick for so long, and then the adjustments and the prolotherapy straightening everything out. I just feel so much better. I don't know how to describe it anymore.
Well, you probably have mental clarity, and it's like there's a fog lifted in your brain. Like, don't you feel like your brain's functioning better?
Yes, and I'm not as anxious as I was. I mean, I don't know. It's awesome.
That's awesome.
Yeah.
And then I think the next thing is, why don't we go look at your test results? Because I didn't even know what your test results showed, but
they're good.
Okay, good. So let's go there.
Okay.
You know, when you first came, we did a cone beam CT scan. Then you had 3 visits, did a bunch of things, wore some weights, had some, made some adjustments with your sleeping and hopefully your computer station. So I don't actually remember if I saw your computer station, so it'd be nice if you just took a picture of it.
Okay.
Because a lot of times people, they actually have to have their computer screen a lot higher than they think they do, because their neck curve is already reversed. So if you want to try to not get into situations where you have problems with your vagus nerve or the jugular veins get compressed and you want to try to reverse it on your own, and if you have a computer job, then you got to have, because you're actually using your workstation as a therapy. So you can't just have it neutral. That's why with you we were saying, well, geez, if you could sleep in a position where also your neck was up a little bit, it would mean that for 8 hours a day you're in that nice curve position.
Right.
But you're exactly right. Like, for some reason we all
over.
It's because and part of it is we're just comfortable with that because we're just looking down all day, and we don't realize how that's actually not good for the human body to be looking down all day. So this is your cone beam. Then we look at whether or not you have styloids, so you don't have a styloid there. And then see on the right side, look at that. So you have that styloid on the right.
Yes.
So when we look at your results, obviously you have a styloid on the right, and that could obstruct your carotid sheath on the right side. So when you look down, just because of this bone here, you could be obstructing your carotid sheath. So we'll see that, on your labs, and also when you look to the right. So people who have styloids on the right, I have a styloid on my right. So when I'm watching TV, I'm looked a little bit to the left. If that hits your right vagus nerve, hits your right vagus nerve, hits your right vagus nerve, well, then you could get a digestive thing, which of course is one of the reasons why you saw us. So I don't think you're going to need it out, right? Because you're already doing better. So part of the reason why we redid this again was to see if this opened up by you getting a better curve. By getting a better curve, your atlas goes back. So then that opens up the space. So it's harder for you to compress the vagus nerve there. The glossopharyngeal nerve is there. That's why I asked you questions about swallowing, because that's involved with swallowing. Then the spinal accessory nerve is there. The spinal accessory nerve that innervates the sternocleidomastoid muscle and the trapezius. So when I smash mine, it's like the muscles just grab. So you don't have any of that happening with you, do you?
I mean, I definitely carry all my tension in my neck and shoulders, but yeah.
So if it ever happens acutely, that's from there.
Okay.
So in the course of, I've been doing this for 30 some years. Well, in January 6th in 2023, it'll be 30 years. So I'm almost at my 30-year anniversary of doing this. So I probably had about 30 cases. Erin's been following many of the cases. Erin, one of the nurses here, she's been calling like some of our patients who've had styloidectomies and just making sure that they're recovering good. But just know it's only been about 30 of our patients who need to actually get their styloids removed. So here, if we look at this, I just want to talk a little bit about This is called the clivoaxial angle. That's that angle. So when you started, it was like 147. So it's pretty good right there. So it's like maybe 153 now. So that, that's just another sign that the structures here are getting into better anatomy and the instability's, starting to resolve. So your dens here, this is that's what your head rotates around. So what you want is the dens to be more straight, not angled so far back. So that's why the curve part of your care is important.
Okay.
So see right here, this is your occiput, this is on the right side, this is your C0, C1, see how it's angled like there. We want this to be a little bit more upright. Okay. So, because we're talking about trying to open up your jugular vein and your vagus nerve on the right. So if we measured this, so we can measure this, we could just measure, I'm just going to do it really quickly, but if we draw a line here, you could see that probably your atlas is about 7 millimeters forward of your occiput. So that would be a number that we want to keep getting less and less and less, because that's going to do what? If this keeps going back, then you're going to have more room for your styloid. So if you do turn to the right, so I don't know if we talked about it, it would be that you should have your papers, when you're at your desk, your papers should be on your left.
Okay.
So I don't think
we talked about that yet.
We don't really realize that, because if you're right-handed, you don't realize how many times you might be turning to the right.
Yeah. Okay.
So that's just another little thing. Here, if we look at, so this is your atlas here, you see that little bone there? So that's probably pretty accurate, 7.5. So we could compare that to your other one. So the jugular vein normally is, in a gal, should be at least 9 millimeters by 9 millimeters. So at least, in the, because we always ask you, this is an upright scan, so we just always ask you, just to be in the neutral position, what's comfortable for you. So comfortable, so you're almost at it where the jugular vein could be completely open there. That's just called the atlantostyloid interval. So that's like one of the things we look at to try to get your jugular vein good. I would say this is probably how almost everybody's neck curve is. It's pretty straight. Now you could see where you're just starting to get, some lordosis. So it's definitely better than what it was. But, if you draw a line here, your atlas still is probably about an inch too far forward. So part of the reason why we do these follow-up exams is I always want to let you know, even if you're symptom-free, what things have absolutely 100% been corrected and what things aren't corrected, because I think you need to know that. Right. So it isn't just that your various symptoms are resolved. You just need to know that if you don't get this curve, you're still going to be at risk of this stuff recurring. Doesn't mean it's going to recur, but right? So
I definitely feel better having the numbers that we got today. I feel better, but I'm happy to see the results too.
But you could see that I know for sure a lot of your numbers are not going to be ideal just because you still have this.
Right.
And then, prolotherapy is not an inexpensive treatment. So if the weight of your head, so your weight of your head is still in front of this curve. So that would be like if I was bent over, and you're my prolotherapist and you do prolotherapy, my back pain goes away, but I'm still hunched over, you'd say, Ross, you can't walk like that, because the ligaments are going to get stretched out again. So does that make sense? So yes. We could see how there's still a little bit of instability. So in other words, C4, C5, C6, C7, that's all fine. But do you see that? Right, so basically based on this, I should go with your prolotherapy here on out, I should go down at least to C4.
Okay.
So, and see, you just look up a little bit, look at that. That's kind of our goal. But you didn't have, you just had to look up a little bit. You have to look up a little bit, and that, look at that, that's perfect. And then see how everything's aligned.
Yes.
Okay, so that's the goal
okay.
for when you're looking forward. Okay, so we look at this, so let's agree, a little bit there, maybe a little bit there, so down to here. So C1, C2, C3, C4, C5. So this is another reason why we do multiple passes, because it's like, geez, why do they, when you go to an x-ray, they just go like this, or they take one spot. Because if the previous thing I showed you, you had instability here, no instability here. But then we're relaxing your muscles, then as your muscles got relaxed, you do have instability there. So that's another reason why we do multiple passes, just to...
And I think the movement, one of the reasons I decided to come here was because you did this under movement, and everything else was, we'll just lay down and take the imaging, but I'm not having the symptoms laying down. And so being able to do the movement was really helpful.
Okay, so your C2, this is the spinous process C2, it's in beautiful alignment. So your alignment's good when you're just standing. Then we're just trying to see, we're looking at this C1, C2. So you start seeing where, it's sliding a little bit. So it's sliding a little bit, but we'll just watch the rest of this. And again, we have to do multiple passes because we have to stress it, because life's stressful. If we just did one little thing, life's very stressful. And then here, we're having you jet out your chin. Now it's very stressful for this joint. So let's see. Okay, so see the left one. See, there's still some instability there. So now this plays a role, because you could see here the overhang here is more on the left side than the right side. So you came because of what I would consider right-sided vagus things, but that's one of the reasons why, like right now, when you first came, your right vagus nerve was smaller than your left. Now it's your left one, because like it could be that this responded quicker than this. So that would be my explanation of why now your right vagus nerve. We always look at, the diameter should be at least 1.5 millimeters. You went from 0.8 millimeters to 1.3. So then we have at least the structural basis of why your Crohn's disease got a lot better, because, your vagus nerve diameter almost doubled. And you could see that the cross-sectional area did double. Like in other words, it's usually a circle. So the cross-sectional area doubled, so that's very, very good. And then, the brain pressure, or the monitor we use for brain pressure is the optic nerve sheath diameter, went from 8.2 to 7.8 on the right. So that, again, is heading in the right direction. It's still high, so meaning that your brain pressure is still high. And if we look at this is probably the most significant result I like to see is, did your jugular veins open? Because the jugular vein, remember I said in the room there, it's normally 9 by 9. Well, you got to realize vagus nerves are 2 millimeters, 1 millimeter. So it's going to be easier to document something that's 9 or 10 millimeters versus something that's 1 or 2. Right. So when you first came, when you were laying down, the jugular vein cross-sectional area at C1 was 20, meaning it was like 4 millimeters by 5. Now it's 66. So the cross-sectional area triples. That means that when you lay down, it's 3 times more open. So obviously you could get the brain pressure or anything else that's by the jugular vein is going to be relaxed, like your vagus nerve. So then the vagus nerve can repair, and of course the brain can drain better.
And I think we talked about last time that's what was causing the pulsatile tinnitus, was that I could hear my blood going down, and I definitely hear it way less now, or less often. So.
Then on your left side, it was even more dramatic. Your cross-sectional area of your jugular vein was 14, now it's 64. So, great job. I mean, it's definitely heading in the right direction.
Great job.
No, but I mean, it's a cooperative. It's a cooperative.
It's true.
And you might say, well, is there any other evidence that things are doing a lot better? So when you first came in, your MCA velocity, so the carotid artery in the neck, it branches off into the anterior cerebral artery and the middle cerebral artery. The one we normally measure in the room or in the office here is called the middle cerebral artery. The velocity of the middle cerebral artery when you're upright, you're at rest, is normally about 65 centimeters per second. So when you're upright and it's over 100, like when you first came, the left one was 102 and the right one was 107. So you're on the highway, and you're going 65 miles per hour. Imagine how fast something is going over 100 miles an hour. So it means that your pressures were so high when you first got here that the brain was so nervous that it was concerned that the arteries were going to collapse. So that's why it dilated the arteries and the velocity was so high. Then based on our test today, obviously if the jugular veins are more open, then you would expect that the optic nerve sheath diameter would go down, which it did, but then we would like to see that the MCA velocities went down. So you see that the right one went from 107 to 77, the left one went from 102 to 66. So that would mean that your brain now isn't under as much stress. So normally what you would feel is you would actually feel less stress, and that's why I was asking you about, do you feel like actually your brain's functioning better?
Yes.
So then, of course, I'm sure at work too, you probably just feel better.
Yeah, I mean, I think that might be the anxiety, and then even like the ability to concentrate, or brain fog is the term that's used now. I mean, way less brain fog than before. I can concentrate for longer periods of time. So.
Awesome.
Yeah.
Here, we were talking a little, you were asking me a little bit about like the pupil size. Mm-hmm. Just know they both did go down. Mm-hmm. They both did go down. I like pupil diameter to show us how's your balance of your autonomic nervous system. So, when somebody's relaxed and their vagus nerves are normal, the pupils normally are pretty small. But imagine if somebody's like in a bad marriage, or they're a colonel in the U.S. Army and there's so much stress. And they don't have a good mechanism to get rid of stress. You don't realize like your pupils, they're just going to be so dilated. Or if somebody's vagus nerves are getting damaged and they have a limited ability to handle stress, their pupils are going to get really big. But if the vagus nerves get healthier, and or the person does some lifestyle modifications, doesn't let stress get to them, the pupils get smaller. So just know, I mean, that's just another sign that your nervous system is getting into balance.
Excuse me. Yeah.
So I think, I'm really happy with the progress, and so obviously this helps me too, that I got a target here. So we'll talk about, if anything, we have to change anything in the solutions or the frequency or whatever. And again, we really appreciate you telling your story.
Yeah.